gentlemen. My lecture is the third of 5 lectures. I'll try to keep to time, the 10 minutes, and so that we can have time for Q&A at the end. I'm a urologist, a non-vascular surgeon, and I've been doing AVF since 1985. So what are some of the challenges and solutions that I can share with you? I think this lecture is part of an unfinished business by Dr. Naresh and Professor Liu during the College of Surgeons meeting in 2019, where they reported that AVF is created by a myriad or myriad, as the Americans call it, of specialists. And it also says during the meeting that the creation of AV fistula in Malaysia does not involve much collaboration. The approach is different. The post-op care is not standardized. And on top of that, there's no formal training curriculum for hemodialysis access. It goes on to say about many unsatisfactory issues like long waiting lists, low success rate, low patency rate, lack of monitoring, lack of maintenance of fistulas, and also the lack of budget. Let's hope that we have a new cabinet, new health minister. We have more budget for our hospitals, government and the private. So why this challenge? Why me? Well, I look at the specialist register, and there are actually only 29 vascular surgeons in Malaysia right now, whereas we have 136 urologists, 105 plastic surgeons, and among the other surgeons who may be doing fistulas, there are plenty of orthopedic surgeons, plenty of general surgeons, almost 1,000 of them, and of course, all these specialties have trainees under their wing. The early nephrologists in 1980s were also doing vascular surgery. So when I was discussing with some friends, including Dr. Anga, regarding this topic of multiple surgeons, Dr. Anga's response is that the sheer volume of access procedures in Malaysia actually required many doctors to participate in providing this service to these patients. So who are the non-vascular surgeons that we are going to discuss? And what are access procedures? From my experience in the Malaysian scene, the non-vascular surgeons are the urologists, plastic surgeons, orthopedic surgeons, and hand surgeons. They are the only one who can guarantee 100% success. But I can't find hand surgeons on our national specialist register. Cardiothoracic surgeons, 84 of them. Some of them are interested in vascular access. General surgeons, medical officers, apparently only in East Malaysia and Penang. Some of them are credentialed to do AVF. The GP surgeons, the nephrologists. Long ago, there are 227 nephrologists. And in fact, I personally think that any person, not necessarily a medical doctor, can be trained to be part of this myriad of people doing AVF. In fact, the ex-head of nephrology service in the Ministry of Health started a Google form to invite registration for AVF surgeons. I don't know how it has come up. So Dr. Ong Yok Meng started a Google form. And the head of plastic surgery during the meeting suggested some national collaboration between the public and private sector. And also there's some discussion whether we should have a register of the endovascular procedures. So in the Malaysian scene, there is room for national collaboration. I'm a urologist and we're at the head start. We started we were organized as the Institute of Urology and Nephrology way back in 1974. So in the early days when I was doing AV fistula, the nephrologist automatically referred the surgical cases to us, and I was happily sharing them together with the plastic surgeon, the hand surgeon, the orthopedic surgeon. There was one vascular surgeon at that time, Dr. Yusha, but he was quite busy, and so he was happy for us to do the AVF. This is the IUN now. There are 7 floors. This is 1985, before I left GHKL for Sarawak. So coming back from Kuala Lumpur to Sarawak, we also started mini IUNs, Institute of Urology and Nephrology, where we work together in the same physical space in the Sarawak General Hospital and also in the Sarawak Heart Center. For the urologists, ultrasound is an extension of the clinical examination. So we just have to add a vascular probe, and the dialysis unit are usually next door to our office. So it is natural that the urologists are in close physical proximity, have all the facilities to do the AV fistula and to follow up the AV fistula. So urological surgery, including cystoplasties for neuropathic bladders, and subsequently for transplantation, this is a continuum of surgical care for the kidney failure patient. As far as clinics are concerned, we also have combined clinics with the pediatric nephrologists. We started in Hospital Kuala Lumpur, and now it is in Sarawakian Hospital and in many other hospitals in Malaysia. So we work very closely with the adult nephrologists and the pediatric nephrologists. And I was closely involved with the pediatric renal transplantation program of Malaysia, although the numbers are small, but they are picking up after the COVID pandemic. And this is in the background of kidney transplantation done by the urologists way back in 1975, when the first kidney transplant was done in Malaysia on Sarawakian young man, where he had the kidney donation from his younger brother. Who are the non-vascular surgeons? I can think immediately of Dr. Angga, who is a well-known senior plastic surgeon. He has been doing AVF since 1988. And in Sarawak, we have Dr. John Ranjit, the head of Department of Plastic Surgery. He has since just retired, and he came to Sarawak and also started the AVF service. What are some of the limitations, which is the second part of my lecture? I think patients who have underlying severe vascular disease or new onset vascular disease, they are the atheropath. I think they're better off referred to the vascular surgeons to assess. For example, patients with bilateral knee, bilateral knee amputation, gangrenous legs, gangrenous toes, grossly atherosclerotic vessels. These patients are probably better off assessed by the vascular surgeons to begin with, and maybe in fact they're not suitable for AVF creation. And if you have to do an AVF of them, they can have severe bleeding to control the atherosclerotic vessels. And sometimes post-operatively, the ischemia manifests itself, and we may have to refer these patients to the vascular surgeons for possible revascularization. The second problem is when the fistula becomes dysfunctional. We can refer them to the interventional radiologist or to the vascular surgeon who does intervention. For example, this patient with stenosis of the juxta-anastomosis vein, the IR can do a venogram, and they can do successful venoplasty. In fact, it's often said that if you have done a good AVF, they almost never require a second operation. What about central vein stenosis? Of course, this has to be referred to the interventional radiologist or the vascular surgeon who does interventional radiology to do balloon dilation so that they can reduce the edema of the upper limb. Secondly, what is access procedure? I mentioned about AVF. Now, we also have peritoneal dialysis. The new head of service of the Ministry of Health, Dr. Sunita, mentioned, it was reported, whether it's true or not, I don't know, that the PD is peritoneal dialysis is the preferred policy in most government hospitals. So the other access procedure, of course, is to insert the CABD catheter. In fact, CABD started in Malaysia in 1984, and that is me in the photograph, 1994. What have I done to deserve to be in this important photograph where the DG of Health then, Tan Sri Abubakar Sulaiman, the head of nephrology, Datuk Zaki, what have I done? What has the urologist done to be invited to this cake cutting ceremony? Well, the urologists are just next door. So I spent almost all my lunch breaks when I was in Hospital Kuala Lumpur putting in catheters. We also put in dialysis catheters because access to OT and fluoroscopy is just part of our endourology work. So I come to my last slide, which I think is the model for collaboration in access procedures. This is a course, the third course, in fact, organized by the Department of Plastic Surgery, started by Dr. John Ranjit and now by Miss Daphne, where the first lecture was given by the nephrologists regarding guidelines for vascular access. The second lecture is given by the paramedical, who are a very important part of this process, on the role of hemodialysis staff in peri-operative counseling. And the third lecture was given by a urologist, that's myself, on the surgical techniques of AVF creation. And the next lecture is given by a vascular surgeon on vascular graft. And finally, we have somebody from Johor Bahru coming all the way to Kuching to talk about fistula maturation and successful use. And hopefully we have more of this. And again, this is the group of vascular surgeons, nephrologists, urologists. We try to improve on this very important care of the patients. So in summary, Mr. Chairman, the take-home message from me is that the actual surgery itself is probably about 20% of the AVS process. If you have a multidisciplinary team, it is important. I think we practice this in Malaysia in different models, in different geographical centers, in the government and the private. There are many patients. I think there's a role for all doctors to participate in this. We need to have audit, continuing efforts in the best interest of the patients. I'm speaking to you from Kuching, and I hope I will be able to participate if you ask me questions in the WhatsApp. Thank you for your attention.